Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Ajay Nooka, Professor of Medicine, Director of one of the most prestigious myeloma programs in the country at Emory University. And he's going to talk to us about some data presented at the American Society of Hematology meeting in 2024, which combined the bispecific antibody Teclistamab with lenalidomide in newly diagnosed myeloma. So welcome, Ajay.
Thanks, Ravi. Thanks for having me. This is always a pleasure for me to come by and have a conversation about the ongoing new studies that are showing good data.
So just before we get to this particular study, just put it in context. So where are we with BCMA-based treatments today? And then we can obviously talk about how this study looked at moving it into frontline.
Absolutely. So if you look at the target antigens in the myeloma, on the myeloma cell, you see BCMA to be expressed ubiquitously, and BCMA is present in mature B cells. And this is an ideal target for myeloma cells, as myeloma being a mature cell. And there are three modalities of treatments that have been evaluated in this space. So I'll talk about the first one, which is the antibody drug conjugates targeting BCMA. So belantamab mafodotin has a payload which is the MMAF, or the monomethyl aristotin F, and this is a tubulin inhibitor. And how this works is it is tagged on to an antibody, and the receptor of this antibody is binding to the BCMA. So once it binds to the BCMA on the myeloma cell, it internalizes, and the payload is delivered directly to the cell and kills the cell. The main reason why it got withdrawn from the market is there were some ocular toxicities that were associated with this specific drug. And as a single agent, that has limited us the ability to deliver more of this, more dosage to the cell. And the expected response rate with the safest dose was in the range of around 30%. We all knew that it's a combination drug, but unfortunately, as a single agent, when it was tried in a phase 3 trial against pomalidomide and dexamethasone in the DREAM3 trial, it did not pan out. So the drug has been withdrawn into the market. So the better news is the new trials of DREAM7 and DREAM9, which have evaluated the combinations of belantamab with pomalidomide dexamethasone, belantamab and bortezomib dexamethasone, have shown such significant responses, and this likely is going to make a comeback in the future. The next class of drugs that really make me excited are the bispecific antibodies. So think about BCMA being expressed on the plasma cell. Now you have a bispecific antibody that is targeting BCMA on the plasma cell, and with the other arm, it is targeting the CD3 on the T cell. So bringing proximity of the T cell to the myeloma cell and allowing for the T cell lysis, allowing for the myeloma cell lysis. So this is a very unique way of addressing the myeloma cell kill, and this has gotten the two drugs that were approved in this space are the Teclistamab, which was approved in October of 2022, and elranatamab, which is approved in August of 2023. These have made it to the mainstream of treatment, and we've been using these for the last 1.5 to 2 years. It is off the shelf, very effective. The response rates are in the range of 60%. And you're able to see the median PFS that for these patients who are triple class refractory, had seen 4 or 5 prior lines of therapy, and the median PFS with this single agent is in the range of a year or longer. The last class of drugs that we see are the CAR T cells, where a synthetic receptor is expressed from a T cell by, again, a proprietary manufacturing, and this T cell, this receptor is binding to the BCMA on the myeloma cell. There are 2 CAR Ts that were approved. One is ide-cel, or idecaptogen varicocel, and this is approved in March of 2021. This gives a PFS in the range of this, similar to what we had seen with the BCMA bispecific antibodies. And cilta-cel, or the ciltacaptogen autoleucel, this was approved in February of 2022. This has been another game changer, but it is meant for only specific patient populations who had a good organ function and younger with minimal comorbidities. And the median PFS you would expect with this regimen is in the range of around 3 years. So very interesting, effective strategies to target the BCMA, Ravi.
So obviously, we're going to talk a little more about teclistamab now. And where is teclistamab used today?
So teclistamab is again a BCMA bispecific antibody that was approved for patients who had seen 4 prior lines of therapy, including a PI, IMiD, and a CD38 monoclonal antibody. So patients must have already seen 4 prior lines to be eligible to receive this drug. Again, this was approved based on an accelerated approval program. That means we saw the response rates to be higher, so it got approved, similar to elranatamab's. And the caveat here is there needs to be a subsequent phase 3 trial showing the benefit of this compared to the standard of care. So those trials are ongoing as we speak.
So obviously, that brings us to the trial that we're going to discuss. And this was looking at teclistamab and combinations in frontline therapy. Could you give us some context as to what the trial is seeking to achieve? And
Absolutely. So I'll give you the perspective of how we treat a younger patient who is transplant eligible and what has given us the best PFS benefit or the best long-term outcomes. And based on that, how this trial is differing and what this trial is specifically answering the questions about. So it starts with younger patients receive an induction therapy of approximately 4 to 6 cycles, preferably a 4-drug regimen, which includes a PI, IMiD, and a CD38 monoclonal antibody, as well as a steroid. And younger patients with good organ functions go to a transplant, and post-transplant, they go on to a maintenance. And here, the maintenance that has been the standard of care is lenalidomide as a single agent. And this is given until progression based on the study that was done by Paul Richardson's group. And this was a determination trial. And the Perseus trial, as well as the Griffin trial, have proven that the quadruplet regimens using the same methodology were able to get us to the deepest remissions in terms of MRD negativity. So that's a background. So the caveats here. So as a single agent, lenalidomide is prone to cause secondary primary malignancies. This is in the range of around 2 to 3%. Number 2, financial toxicity. The lenalidomide as a single agent, given for a longer period, it costs $250,000 per year. And this, even though this is FDA approved, you're exposing the patients to a longer treatment for the prolonging the PFS. So what this question in EMN 30 did was, hey, can we see if there's an alternative regimen that could be given for a shorter period of time to gain the depth of response and be done with a fixed duration of maintenance than continuing this maintenance for a longer period? That is the basis of EMN 30 trial. And the beauty about this trial is the safety run-ins are done in 3 cohorts. Number 1, you need to show, yes, this is safer to use a bispecific antibody in a newly diagnosed patient in the maintenance setting. And number 2, is it good enough? Which is the right strategy to move forward? So is the same dosing and the schedule that has been approved in the later lines of therapy, is it the most optimal dosing and schedule? We don't know that. So that was the reason why there are 3 safety run-in cohorts that were evaluated here. And I'll start with the first one. The safety run-in cohort 1 combined teclistamab plus lenalidomide. Here, weekly dosing is given for the first 2 months, like daratumumab dosing. And then the second 4 months, it's every other week dosing is done. And after the first 6 months, patients would receive every month. In cohort 2, teclistamab is given every 4 weeks. The caveat here is the weekly dosing was approved at 1.5 milligram per kilogram. And here every 4 week, the dosing was given at double the dose. So it's 3 milligrams per kilogram was given in combination with lenalidomide at 10 milligrams, which is a standard maintenance dose. And the safety run-in cohort 3 used teclistamab every 4 weeks as a single agent here as well. So again, very good study. Patients would receive 4 to 6 prior lines of therapy, either a 3-drug regimen or a 4-drug regimen. Patients must have received transplant, may or may not have received consolidation. And these patients are randomized to one of these 3 arms. And the patients were assigned to one of these 3 arms. And the patients are given a fixed duration of maintenance for a period of 2 years. And that's the duration. And why are we doing? And what exactly is the primary endpoint? Here it is the progression-free survival, and a second primary and second or a co-primary endpoint is a 12-month MRD negative complete remission. There are several other key secondary endpoints that were evaluated, including the CR rates, the MRD negativity in general, as well as overall survival, PFS2, the time to next treatment, safety, several other secondary endpoints were evaluated as well, Ravi.
I think you've touched upon the dosing here. Is there anything else you think our audience needs to know about this slide?
Yeah, so the teclistamab is given as a step-up dosing, so it's given at 0.06 milligram per kilogram as a step-up dose 1, and 0.3 milligram per kilogram given as a step-up dose 2, and the target dose at 1.5 milligram per kilogram is given. All these are separated by 48 hours apart. And the target dose of 1.5 milligram per kilogram given weekly is the approved dosing. And at 6 months, they could go to every other week. So that is the approved dosing for patients who have relapsed refractory myeloma who had seen four prior lines of therapy, including a PI, IMiD, and a CD38 antibody. Now, if you look at the dosing here, is when it goes to every other week in cohort 1, the dosing is doubled to 3 milligram per kilogram, and cycle 7 to 26, the dosing is at 3 milligram per kilogram given every 4 weeks.
So what is the demographic or the patient population in the study?
Yep. As expected, this is a younger patient population. So all the 3 cohorts had patients who are less than 60 years old, and above 65 accounted for a handful of patients. So around 12 patients in cohort 1, 5 patients in cohort 2, and 9 patients in cohort 3. This is done as a part of the European Myeloma Network. All patients are expected, as expected. There is high preponderance of males, and white patients accounted for 100% of these patients. And the expected ISS staging is similar to what we see in general in the clinic. These are small sample sizes, so I would not worry much about the percentage, but around 20 to 30% is what I would expect to see in ISS stage 3 disease, and that's what we're seeing here. High-risk cytogenetics is, again, representative across all groups similarly. What is quite interesting here is the PI plus IMiD was seen in a higher proportion in the cohort 1. So that's a 3-drug regimen compared to a 4-drug regimen, which was seen in much higher proportions as in here in cohort 3 and cohort 2.
And so how did patients tolerate this regimen?
So from a maintenance perspective, so we expect, because the dose intensity is much higher from a teclistamab perspective, so I would expect more higher toxicity in cohort 1. So that is exactly what we had seen here as well. So neutropenia of close to 93%, almost everybody had neutropenia. And what you see in grade 3 and 4 is the same number of people who had a higher grade neutropenia. 93% of the people had grade 3 or 4 neutropenia when patients were receiving the similar dosing of what was given in the relapse setting. So when you ease down the dosing in combination with Len, so that number drops down to 2/3 of the patients. Almost everybody has grade 3-4 neutropenia. Now here, only 2/3 of the patients have. When it comes to a single agent, as expected, you see half the patients having this grade 3-4 neutropenia. This is nothing different than what I would have expected. And what is more interesting to me is the dose delivery, the relative dose intensity. So what is your intended dose of teclistamab and how much was delivered? That was significantly higher, more than 95% across all these cohorts. And with lenalidomide, there was around 60%. Treatment discontinuations were altogether, it was 5.3%. But if you look closely into the abstract, so that number was much higher for cohort 1 compared to cohort 2 or cohort 3.
And then as far as the non-hematological toxicities go, what was seen?
Whenever we're talking about bispecific antibodies, the unique toxicities that are associated with bispecific antibodies and CAR-Ts are the cytokine release syndrome as well as ICANS. What is very interesting is we have not seen any ICANS in all these three cohorts. The CRS rates, most of these are grade 1 or grade 2, and grade 3 CRS is seen in 0% of the patients. So that is the take-home point. So 50% is what was seen in the first cohort, around 40% was what was seen in cohort 2 and cohort 3. So the combination with lenalidomide did not increase the risk of CRS. The combination in lenalidomide did not increase the risk of ICANS, as there is no ICANS that was seen. The combination with lenalidomide did not increase the risk of infection significantly as well. So I'll give you a relative context of the infections. In the first study that was ever done, the Majestic-1 study, the risk of grade 3-4 infections with teclistamab is in the range of around 60%. So 3 in 5 people have been hospitalized when they receive teclistamab on a weekly basis in the relapsed refractory setting. Here you don't see those numbers. So those numbers are higher, but not those numbers are higher relatively to compare to other myeloma treatments. But for a bispecific antibody, these numbers are very manageable, seeing at 12% to 9 to 10%. All grade infections are seen in around 30% of the patients, and that could be significantly reduced by offering the immunoglobulins for hypogammaglobulinemia, as well as keeping a close watch on the infectious prophylaxis and so on.
So I think you talked to some of the content here in this slide.
Yeah. So when you look at these infections, the grade 3-4 infections, you're seeing in 37% in cohort 1, just as we talked about previously, and around 28% in cohort 2. And when hypogammaglobulinemia that needs an IVIG or intravenous immunoglobulin administration, the threshold is at the range of 400 milligram it's at the threshold of 400 milligram per deciliter. When you look at the when you look at the hypogammaglobulinemia, in cohort 1, it was seen in 96%. In cohort 2, it was 78%. In cohort 3, it was 93%. All of these patients have received more than or equal to 1 gram of, all these patients have received at least more than 1 dose of IVIG or subcutaneous immunoglobulins. There is one unfortunate event in cohort 2, which is a COVID-related event. It is a COVID-related death that happened in cohort 2, where the teclistamab was given every 4 weeks with lenalidomide at 10 milligrams.
So what is the preliminary efficacy results?
This is a very effective strategy in terms of delivering maintenance for a fixed duration of patients. This is a very effective strategy to deliver maintenance for a fixed duration. And we have to understand what the primary endpoints are. We have primary endpoints of PFS and the primary endpoints of MRD negativity at 12 months. So here, what we are seeing is this cohort 1, which was enrolling early, had a median follow-up of close to 22 months. The cohort 2 and cohort 3 had a median follow-up of close to 10 months. So that's why you don't see all the patients being evaluated for the MRD negativity. And when you see 30 patients post-transplant were evaluated for MRD negativity in cohort 2, MRD negativity at 6 months was evaluated only in 26 patients. So this is an ongoing evaluation. So, but what you can see here, whoever is evaluated at the 12 months in cohort 1, which has the longest follow-up, you see 100% MRD negativity at 10-5. Similarly, at 6 months, among the 26 patients, MRD negativity at 100%. At 6 months in cohort 3, among the 22 patients, it's 100%. Deeper responses are seen with these combinations irrespective. The question that then comes is, which is the safest one to move forward as we started these safety runs across these 3 cohorts, and seeing such good responses, such deeper responses, and safety becomes the primary factor to determine which safety cohort to go with for the long run in terms of the later part of larger randomized phase 3 trial.
So what is the key takeaway at this point of this study?
So what we had seen is more than 90 patients were treated with these combinations. So we also had the luxury of having a control arm with teclistamab alone. So what we had seen with cohort 1 and cohort 2 is with addition of lenalidomide, the toxicities were not too high. The toxicities were similar to the teclistamab monotherapy arm. Number two, there are very few rates of discontinuations. Almost 95% relative dose intensity was delivered. So most of the patients received the dose of teclistamab just as intended to. And what you also were able to see was cohort 1, which was more dose dense, where we're giving weekly dosing for the first 2 months and every other week for the next 4 months before going on to every 4 weeks. There, the dose density has resulted in more toxicity. I would not view that as the arm that would be moving forward, neither cohort 3, where teclistamab was given as a single agent, and cohort 2, where I can see a significant balance between the MRD negativity rates as well as the combination to be safer. I feel comfortable, and it is left up to the investigators to see whether they will be moving forward to cohort 2 or cohort 3 as an expansion.
So how do you approach your maintenance today, and how do you foresee such strategies changing your approach in the future?
So maintenance is a misnomer. When you start patients on maintenance as a single agent, you expect to see those the maintenance therapies deepening those responses over time. That happens with lenalidomide. Here, what I'm seeing is that the MRD negativity, if you consider that as the deepest response, you're able to achieve with changing the maintenance therapy, which leaves us with a lot of questions. Is there an opportunity for us to get away with continuous maintenance and have a fixed duration of maintenance as a new strategy for us to get to the deepest remission and get the long-term outcomes that we're looking for? So studies like this would allow us to answer those questions, especially with a lot of secondary endpoints that were being evaluated that will help us to go to the next phase of the next journey, where we want to achieve those deepest remissions in terms of MRD negativity with a fixed duration of therapy with combinations.
I really appreciate your taking the time to educate the audience about these key developments and where the field is moving in the post-transplant setting. And I hope to have you back in the near future to tell us about further advances in this area.
Absolutely, Ravi. Anytime. Have a
Thank
great day.
you. Thank you very much.